Hello everyone, my name is Natalia Serrano. I am 34 years old. As most of you know, I'm a pediatrics intensivist, so that means I first did my residency in pediatrics and then a fellowship in intensive care, which I have recently finished. Apart from being a doctor, I love running, especially trail running, since I enjoy nature so much. Just very quickly, in the picture on the left, you can see the hospital where I grew as a doctor and where I am currently working now. It is called Garrahan Hospital, and it is one of the most important pediatric hospitals in Argentina. The picture on the right was taken last year. There you can see my team and I getting ready for a trail running being held in Tandil, which is a part of Buenos Aires province in Argentina. Now, the idea of this presentation is to analyze an article and discuss the statistical analysis, applying everything I have learned in Module 2. So, I will try to do my best. So, this is the article I chose to analyze. It was published by Ellenberger and colleagues in 2018. It is called Myocardial Protection by Glucose, Insulin, Potassium in Moderate to High Risk Patients Undergoing Elective On-Pump Cardiac Surgery, a randomized controlled trial. Since I started PPCR, many ideas about what and how to do research in my field came across. One of them arose from a case that really caught my attention some months ago. It was about a 14-year-old patient, previously healthy, whose only pathological history was 1 month length of constipation. Because of that, he visited the hospital and he was admitted for treatment. 48 hours later, he developed an intestinal perforation, reason why he was urgently taken to the OR. In the ICU, we received him post-surgery, critically suffering from a septic shock, ventilated with high doses of inotropes, and 2 hours later, he suffered from a cardiac arrest. After CPR and trying to stabilize him as much as we could, he continued suffering from refractory septic shock, adding now a severe myocardial impairment. At this moment, the boss and one of the most experienced doctors there suggested using an infusion of glucose, insulin, and potassium. They argued that this had been used in adults to improve myocardial function after infarction and cardiovascular surgeries. And although nothing has been published in children, there is some evidence in adults who suffered septic shock with myocardial impairment. So, as you can see in the picture on the right, after checking that nearly no side effects were reported and knowing that our patient was so critically, we decided to try it. Now, what happened? After 6 hours, the patient was much more stable, allowing inotropes to be diminished and even stopped. So here comes the point where I had more doubts than facts. Did this infusion really work? Was it just luck? Is there evidence about this? So once the shift ended, I came home and started looking for evidence in literature. I found lots of evidence in adults using it after myocardial infarction or cardiovascular surgeries, but only little information about septic shock with myocardial impairment, and not even one randomized clinical trial. That is when I started thinking that I could work on planning an RCT for children over 30 kilos, let's say, or 13 years old who suffered from refractory septic shock with myocardial compromise. And that is one of my main ideas. Having mentioned that, I would like to focus on this article, which is one of the few RCTs related to my topic of interest. Although it is not the same population, the intervention and its impact on the heart is the main outcome. Due to the lack of evidence related to my topic, I would like to use this one arguing biological reasoning. So, starting with the PICOT question, regarding the P component, the population, it's patient with severe aortic valve stenosis and or coronary artery disease who were scheduled for a cardiac surgery which required bypass and who had a mortality risk score over than 7. As regards intervention, it was glucose, insulin, potassium solution. Regarding the control, it's just saline solution, and the outcome was incidence of post-cardiotomy ventricular dysfunction, which is a surrogate of low cardiac output syndrome, and it was measured 48 hours after weaning from cardiopulmonary valve. This outcome was diagnosed by the need of inotropes and worsening of cardiac function assessed by cardiac ultrasound. And finally, the T component was not specified. I think it was till discharge, because that is the point where they still measured the secondary outcomes, but honestly, I'm not sure about that. Although I won't focus on this, just for you to know, insulin is believed to improve cardiomyocyte survival through complex metabolic pathways, which, due to time factors, I cannot mention here. So what I believe that it's the most important thing to remember is that this intervention could be important whenever myocardial is suffering, such as post-cardiac surgery or even in hypodynamic refractory septic shock, because it might improve cardiac output by increasing myocardial efficiency. This is just table 1, which shows the baseline characteristics of the patients who underwent cardiac surgery, both the ones who received placebo or the intervention. So I'm going to start with the statistical analysis of the primary outcome. And as we learned in Module 2, first we need to recognize and understand the variables. As regards the independent variable, the intervention, it's the glucose, insulin, potassium infusion, which is a categorical variable because either you receive the infusion or you don't receive it. Then, as regards the outcome, the dependent variable is the incidence of ventricular dysfunction, which is also categorical because it is either you have a dysfunction or you don't have the dysfunction, yes? Then we have to see if there are important confounders or covarieties, and in this case there are. Then I'm going to show you which are those. And for taking this into account, the authors decided to choose chi-square and then multiple logistic regression for adjusting for covarieties. Now, was this appropriate? We are going to analyze it in the next slide. So let's look at table 3 with the results. The red square shows the primary outcome and the purple square shows the secondary outcome I chose to analyze. Now, paying attention to the primary outcome, we see that in the placebo column, 45% of the observations developed cardiac dysfunction compared to 18% in the intervention group. When we compare the differences we see that the p is less than 0.001, meaning that the differences between the groups are statistically significant. Also, if we pay attention to the relative risk, we see that it is 0.41, meaning that there is a protective relationship between the intervention and the outcome with a trustable confidence interval because it does not pass through number 1. So chi-square, was it appropriate? Let's see. Since the independent variable is binary and the dependent variable is also binary, the authors decided to use this test with the aim of comparing proportions, looking for the association between two or more variables. Just to remember, as it is a non-parametric test, it does not have to fulfill many assumptions, but it is important to take into account that a frequency of at least 5 observations in each cell is needed because with a smaller sample size, this method becomes inaccurate, increasing the number of type 1 errors. If that was the case, then Fisher's exits should have been used. As a conclusion, I think that taking into account the variables, the question of interest, and the assumption of this statistical test, the choice was appropriate. After that, the authors decided to use multiple logistic regression, which studies the relationship between a binary response variable and multiple influencing factors. In this case, they chose to consider as important covarieties age, gender, left ventricular ejection fraction, the scorer of risk, diabetes, type of surgery, and the duration of the cardiopulmonary bomb. Now, was this appropriate? I think it was because it is very important to realize if the outcome was affected by such important covarieties as these are. So I agree with the authors on doing log regression to analyze this outcome as well. So let's focus now on the secondary outcome. The one I chose to analyze is troponin level assessed in the day 1 and 2. So as we did with the primary outcome, first we need to recognize and understand the variables. In this case, of course, the independent variable is the same, which is the glucose, insulin, potassium infusion. But now the outcome is troponin level, which is continuous, it's numbers. So the authors decided to use Wilcoxon rank sum test. Now, is this appropriate? So, taking into account that the independent variable is categorical and the dependent variable is continuous, there were only two options to analyze this outcome, that were the t-test or the Mann-Whitney or Wilcoxon rank sum, to test the null hypothesis, that was that there are no difference between the groups. Now, what the authors need to do, and they perfectly explained it, is to assess normality. For that, they used the Kolmogorov-Smirnov test, and after realizing that the data was not normally distributed, they decided to use the Wilcoxon rank sum test. Now, yes, to check and to test the null hypothesis, that in this case was that there were no differences between the median of the troponin levels of the intervention and the control group. Now, just an extra comment, I would like to say the N of the study was 222. I think that another possibility was to argue that due to the central limit theorem, the t-test could have been also used. Although it is not wrong, I think that maybe a parametric test would have been more powerful in this case. Size calculation, as we all know, we need to focus on 5 components: the alpha, the beta. If there's a continuous outcome, we have to look for the standard deviation, the effect size, and the dropouts. In this case, the authors report the alpha of 0.05, the power expected of 80% with that statistical test. As the outcome is categorical, they looked for proportions, and the effect size was based on literature. They saw that in a previous cohort reported a baseline incidence of cardiac dysfunction after surgery of 38%, and they expected a reduction of 50% using this intervention. Regarding dropouts, although they account for dropouts because they mention it, they don't report what percentage they use to calculate the sample size. As a conclusion, I think that the sample size was correctly calculated, and something very important is that the authors gives us all the information to check it.